Imagine a child who keeps coughing, struggles to gain weight, and has salty tasting skin. These are clues to cystic fibrosis, a life-limiting genetic disorder affecting multiple organs through thick, sticky secretions. Cystic fibrosis is an autosomal recessive disease caused by mutations in the CFTR gene on chromosome 7. The CFTR protein normally functions as a chloride channel on epithelial cells. When defective, chloride can't exit the cell, sodium and water follow inside, and secretions become dehydrated and viscous. The most common mutation is delta F508, leading to a misfolded protein destroyed before reaching the membrane. Pathophysiologically, this results in airway obstruction, chronic infection, pancreatic insufficiency, and increased sweat chloride. In the respiratory system, thick mucus blocks airways, causing persistent cough, wheeze, and recurrent infections, first with Staph aureus, later Pseudomonas aeruginosa. Over time, this leads to bronchiectasis, digital clubbing, and eventually cor pulmonale. Nasal polyps and chronic sinusitis are also common. In the gastrointestinal tract, blocked pancreatic ducts cause exocrine pancreatic insufficiency, leading to steatorrhea, malnutrition, and fat-soluble vitamin deficiency. Meconium ileus may appear in newborns, and older patients can develop distal intestinal obstruction or CF-related diabetes. The liver may develop focal biliary cirrhosis and portal hypertension. In the reproductive system, most males have congenital bilateral absence of the vas deferens leading to infertility, while females may have thick cervical mucus and subfertility. Sweat glands fail to reabsorb chloride and sodium, so sweat chloride and sodium concentrations rise, giving the classic salty skin and risk of hyponatremic dehydration. Diagnosis begins with newborn screening using immunoreactive trypsinogen, followed by confirmatory testing. The sweat chloride test is gold standard. Values over 60 millimoles per liter are diagnostic. Genetic analysis confirms CFTR mutations, and nasal potential difference testing can assess ion transport. Management focuses on airway clearance, infection control, and nutritional support. Daily chest physiotherapy, nebulized hypertonic saline, and Dornus alpha help clear mucus. Chronic azithromycin and inhaled tobramycin or colistin reduce bacterial load. CFTR modulators such as ivacaftor, lumacaftor, tezacaftor, and alexacaftor target the underlying mutation and improve survival. Patients require a high-calorie, high-protein diet, pancreatic enzyme replacement, and fat-soluble vitamin supplements. Advanced disease may need lung transplantation. Complications include bronchiectasis, respiratory failure, pneumothorax, hemoptysis, cor pulmonale, CF-related diabetes, and male infertility. Cystic fibrosis is no longer the childhood death sentence it once was. With targeted therapies, patients are living into adulthood and beyond. This is the Why Medic, Simplifying Pulmonology. Subscribe for more high-yield topics.